Welcome to our second half of our lecture on the heart and the cardiovascular system and blood and immunity. We'll look at some combining forms that refer to the blood. Some of these you've seen before. We talked about myelo when we talked about the skeletal system. If you remember, myelo has a double meaning. It means both bone marrow. It also refers to the spinal cord. So we will see myelo again in a few lectures when we talk about the nervous system. Anything with heme in it refers to blood. Erythro you've seen as a term word before. That means red. Leuco means white. In the context of the blood and the immune system, we're talking about the cell, a leukocyte or an erythrocyte. Lympho refers to lymphocyte. Thrombo, this is a word that I would know for the quiz. Thrombo means a blood clot, or has something to do with blood clots. A thrombocyte is a cell that makes blood clots. Some suffixes here, these you should also definitely know for the quiz. So emia or hemia refers to any kind of condition of the blood. The example they give here is polycythemia. The one that you're probably more familiar with is leukemia, the cancer of choice for young adult novels. Leukemia is a cancer of the blood. Penia refers to a decrease in something or a deficiency in something. And then this word here, poiesis, refers to creation or formation. This is a Greek word, poiesis, and this is actually where we get our English word poetry. Lots of chemistry terms here. Some of these you will recognize, some of these not so much. Azo refers to stuff with nitrogen in it. Calci hopefully is self-explanatory. This is referring to calcium. And hopefully oxy is self-explanatory as well. Anything with Fer is talking about iron, as is sidero. One is Latin, one is Greek. Kali is potassium, and natri is sodium. All right, let's talk about blood. If we were to take a blood sample out of you, whole blood, stick it in a centrifuge, or stick it in a tube, and then stick that tube in a centrifuge and spin it a whole bunch for a long time, when we pulled that tube out of the centrifuge, this is what we'd see. A tube with a little bit of kind of yellowish straw-colored fluid at the top, and then a big yellow clump, if you will, down at the bottom. The yellow stuff at the top of the tube is called plasma, and this is the fluid in the blood before it clots. We did not let this blood sit and clot, we just put it in the tube and put the tube straight into the centrifuge. Blood plasma is mostly water, 90% water, that fluid that's in your blood. The rest of your blood plasma is a whole bunch of stuff. We find nutrients, the stuff that you've absorbed from your food, electrolytes, sodium, potassium, calcium, chloride, magnesium, gases, a little bit of oxygen, mostly carbon dioxide, which we'll talk about next week, I believe. Albumin, which is a protein that helps you maintain your water balance in your blood. It helps keep plenty of water in your blood. But we also find lots of other proteins in your blood as well. These proteins play a number of different roles. Some of them are little carrier proteins. So think about the last time you went to Walmart, King Soopers, maybe back in happier times, and think about the little bottles of vitamin E oil that they have in the vitamin and supplement section. You've seen those probably. That stuff is an oil, and if you were to take a vitamin E capsule, or if you were to eat a piece of salmon that has a lot of vitamin E in it, that vitamin E is going to be absorbed into your blood so that it can go to various cells all over your body. But vitamin E is, like we just said, an oil. And will oil dissolve into your watery blood? No, it will not. You can't dissolve oil into blood. So to get around that, we have a tiny little protein called a carrier protein. And we're going to stick that vitamin E on that carrier protein, and that carrier protein will carry our vitamin E all throughout our body to get it where it needs to go. Other proteins that you find in the blood, clotting factors, we will talk about these in a little bit later on in the lecture. These are what help your blood clot. Antibodies, we'll talk about these in just a minute. Antibodies are your protective factor. They're the little marker that your white blood cells make to label something as foreign. These proteins right here are really important. If you do not have them, or if you do not have high enough levels of them, or if they're not working properly, you're going to have a bad time. If you aren't making your little carrier proteins or your albumin, you're going to have issues with keeping the right amount of water in your blood. If you don't make clotting factors, your blood is not going to clot properly. So when you cut yourself, you'll bleed a lot. That's called hemophilia. If you don't make antibodies, you aren't able to respond to infection or to invaders. So you'll be prone to getting very sick very easily. There's a lot that can go wrong if these proteins are not working properly. And we do sometimes see cases where a person, say, doesn't make a clotting factor and they have hemophilia. When that happens, we have to give that person that clotting factor because they can't live without it. And we get these clotting factors or antibodies or anything else that we need via plasma donation. You've probably heard of plasma donation. This is a separate entity. This is not the same as blood donation. Two different things. If you've ever donated blood, you know that it's a pretty quick and easy procedure. You go in, they ask you all the questions to make sure that you're eligible. They hook you up to a needle and a little bag, and it takes 10-15 minutes. You donate a pint of blood, 2 cups of blood, and then they give you juice and cookies, and they say, thank you, come back in 8 weeks. And they send you on your way. By the way, if you have the time to, you should definitely be donating blood right now. They need a lot of it. If you have ever donated plasma, though, or if you have watched the procedure or know somebody who has, you know that plasma donation takes a really long time. It takes a long time for you to get screened because there are lots of questions that they ask you, which are very similar to the questions that they ask you for blood donation. But then when you get back to donate plasma, the machinery is very, very different than when you're donating blood. When you donate plasma, you get hooked up to a machine that draws blood out of your body, spins the blood in a centrifuge, and in that centrifuge, it siphons off the plasma. The red blood cells sink to the bottom of the centrifuge, and then the red blood cells go back into your arm, and then they draw out blood again and they spin it. This is called plasmapheresis, the technique of just taking plasma out of a person. This can take a while. This can take usually 45 minutes to an hour to get plasma out of your patient. Now, the other big difference between blood donation and plasma donation is that after blood donation, you can't come back for another 8 weeks or so because you got to make more blood. If you just keep donating plasma donating blood every day, you eventually will have no blood, and then you will need the blood transfusion. But if you are donating plasma, it only takes about 48 hours for you to replenish the fluid and the proteins that you lost. So you can go back and donate more plasma again after 48 hours. You can do that right now. The legality is you can do that twice in 1 week. Donate plasma twice in a week. And again, the reason for that is because you're taking out fluid and proteins. You're not taking out red blood cells, and your body is constantly replenishing those fluids and replenishing those proteins. So that is why we do plasma donation, because the only place where we can get these proteins, albumin, antibodies, clotting factors, is from another human. We can't grow them in a lab. We can't train a little E. coli to grow them for us. They have to come from another person. So if you're not currently donating blood or plasma, you need to do one or the other. Pick one. relative acidity of your plasma is about 7.4, which is just a touch over neutral. pH refers to how acidic or how alkaline something is. pH goes on a scale of 1 to 14. 7 is right here in the middle. If you're down below 7, you're acid. So this would be something like vinegar or lemon juice or the acid in your car battery. If you're above 7, this is a base or something that is alkaline. So this would be something like baking soda or bleach is a base. Lye is a base. Your pH likes to be right around neutral. Neutral is what water is. Water is neither acidic nor basic, hopefully. If the water out of your faucet is acidic, please contact somebody. So let's look then at the formed elements, the actual cells that you see in blood. Your blood cells are made in your red bone marrow. Hopefully you remember that from when we talked about the skeletal system. And you have 3 types of blood cells: red blood cells, white blood cells, and platelets. And you commonly hear these guys referred to as formed elements. And that's just to distinguish them from the plasma in your blood that is just liquid. It's not a cell that your body made. Most of your blood cells, before you are born, while you are hanging out in a uterus, most of your blood cells are made by your liver. At about month 7 or so, your bone marrow takes over, and then your bone marrow makes your blood cells for the rest of your life. Most of them come from your axial skeleton, your vertebrae, your sternum, your ribs, and your pelvis. This is one of the reasons why we do bone marrow transplant if we do a complete bone marrow transplant from the pelvis. It's a big bone, it's easy to get to, and it has a lot of bone marrow in it. So these are your 3 formed elements right here. And I really like this slide because it shows, like, kind of practically the different percentages of each blood cell type that you have. So you see here we've got a whole bunch of erythrocytes. That's all these little red guys right here. One great big leukocyte chilling right there in the middle. And then a tiny little smattering of platelets, one here and here and here, and 3 little guys here, one there. And this is pretty comparable to what you see in your blood. The vast majority of the cells in your blood are erythrocytes, little red blood cells. And the whole point of an erythrocyte is to carry oxygen through your body. And erythrocytes do this via a little molecule, a protein called hemoglobin. Hopefully you recognize hemo in that. That means blood. Globin just means a protein, a globin-shaped protein. And within hemoglobin, you find little iron porphyry rings. And that iron in the hemoglobin is what the oxygen, that should be an O, what the oxygen attaches to as it's being carried through the blood. This is why your blood is red. What happens when we mix oxygen and iron together? Think about your cast iron pan, maybe that got wet and then you left it to sit out. What happened to it? It rusted. And the same is true here. You're seeing an oxidation reaction between the oxygen and the iron, and the oxygen is causing the iron to oxidize. That's why your blood looks red. Now, I always have a student or two ask, okay, but the veins in the back of my hand and the veins in my arm, they look blue, they look green. Isn't your blood blue in your veins? No, your blood is not blue in your veins. The reason why your veins look blue is because that's the wavelength of light that gets reflected back off of your veins. The red light gets absorbed by your skin. But no, your blood is still red inside your veins. So like I said, erythrocytes are the most numerous of all your red blood cells. 99% of your blood cells are all erythrocytes. They live fast and die hard. They have a very, very short lifespan. And the reason for that, if you look at our little red blood cells right here, they almost look like they have a little hole in them, like right here, right here. It looks like a donut, but somebody didn't quite cut the center out of the donut. And it looks like that's what's going on there. The reason for that is because after a nucleus, or after a red blood cell is made, its very last step before it gets released into the blood is to spit out its nucleus. It is an enucleated cell. But remember what we found in the nucleus of a cell? Think way, way back to lecture number 2 when we were talking about a little bit of cell bio. In the nucleus of a cell, we find DNA. That's our genetic material that tells us not just how to make the cell, but that's also our repair manual for how we fix the cell if something in it breaks. So if we spit out the nucleus, we don't have any more DNA. If something in the cell breaks, we're not going to be able to fix it. This would be the equivalent of if you never took your car in to the mechanic. The check engine light comes on, you just stick some tape over it so you can't see it. It starts making that terrible sound, so you just turn the radio up. Maybe you already do that, I don't know. You're out of oil, so you just, I got some Kool-Aid that I'll put in there. How long is your car gonna last? Not long. It's probably gonna blow up on the highway, hopefully not with you in it. And the same is true of your red blood cells. If you don't have the repair manual for your red blood cells, they don't last very long either. The hormone that regulates red blood cell production is called erythropoietin. There's that suffix that I told you should know for the quiz. Poietin is Greek. It means creation or formation. Erythropoietin is made by the kidneys. And the kidneys, generally speaking, are keeping track of how many red blood cells you have and when we need to make more. On average, you're making about 2 million red blood cells every second. So 120 million red blood cells a minute. I'm not going to keep going with that math because we get really big numbers with lots of zeros. You're making trillions and trillions of these suckers every day. I like this picture. This is a capillary right here that we see. And here's our little red blood cell. And you can see he's almost bent in half, making his way through that tiny little capillary. Second type of blood cell that we find in the body is the leukocyte. Leuko means white. These are our white blood cells. There are 5 different types of white blood cells that you find in the body, and we divide them into 2 categories, granulocytes or agranulocytes. And hopefully you remember that prefix A just means without. So one looks like it has little granules in it, one doesn't. Our 3 granulocytes are neutrophils, eosinophils, and basophils. Neutrophils are the first white blood cell to show up when you have an infection. So you are out walking, you get cut on a tree branch, and the tissue that's been damaged will send out chemicals that alerts the nearby white blood cells that it's been damaged. And those neutrophils sense those chemicals and come to that site of damage. And then they release chemicals that draw all of our other white blood cells to the area. Eosinophils respond primarily in parasitic infections, parasitic reactions, or in cancer. Basophils are much more active in allergic reactions. And then you have your agranulocytes, which are lymphocytes and monocytes. Lymphocytes make antibodies. We'll talk about antibodies in a little bit. They also destroy infected cells. You see this a lot with viral infection. If you have a viral infection in a cell, the lymphocyte will come and trigger the destruction of that cell. It's kind of the equivalent of burning your house down while the robber is still in it. You lose the house, but also you burn down the robber. So your body thinks that that's a fair win. Monocytes do phagocytosis. The combining form phago means to eat or swallow or engulf. So monocytes go around and they swallow up bad invading cells. They swallow up bacteria or viruses or fungi. Now you have different numbers of each of these cells in your body. Most of your white blood cells are neutrophils. Between 40 to 80% of them should be neutrophils. Next highest is your lymphocytes, because they are making antibodies and checking all of your cells to see if they're infected with viruses. Then after that, you have monocytes, your phagocytes, who are going around eating bad stuff. After that, a little bit of eosinophils and a little bit of basophils. And these numbers are really important because if one of these is off, that can give us an indication of where to start when we're looking for infection. Maybe your patient comes in and instead of a little bit of eosinophil, their eosinophil rate is sky high. Okay, maybe we're dealing with a parasitic reaction here. Maybe we're looking at cancer. So that's what we look for when we do a complete blood cell count for all of our little white blood cells. So what is an antibody? We've already used that word a lot in this lecture. You're going to see it visit a lot as we go through the rest of this lecture. Antibody, and we abbreviate them AB, is a protein marker for something foreign. We'll just say foreign stuff. It could be a bacteria, it could be a virus, a parasite, a protozoa, anything. But it's a little protein marker for foreign stuff. This is the body's equivalent of sticking the kick me sign on the back of the kid that you didn't like in middle school. None of us did this, I'm sure. Let's say we have a little virus. Here's your COVID-19 virus. Boo. He's chilling in your bloodstream. And let's say, I don't know, you're part of the team that got vaccinated to test the new vaccine for COVID-19, and you get exposed to COVID-19. So you've been vaccinated, your body has been exposed to COVID-19, has learned how to make antibodies. These little antibodies, they look like a little Y, a little upside down Y. They're just chilling, hanging out in your bloodstream. We'll look in a little bit at how they're made and how they work. But they just hang out in your bloodstream all the time. And then when one of them comes in contact with a pathogen, the pathogen for which it's specific, antibodies are specific. You don't just get like one antibody that cures everything. This is not like Lord of the Rings. But when those antibodies come in contact with the pathogen for which they are created by your body, then we have what we call an antibody-antigen complex. So the antigen is anything that triggers antibody production. In this case, the antigen is our little COVID-19 bacterium. Now, you have white blood cells, your macrophages will see this antibody-antigen complex right here, and your macrophage will come along, and he's kind of like Pac-Man, and he'll come along and eat up that little COVID-19 bacteria. Yum, 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 right down the hatch. This is how your immune system is supposed to work, and this is also a gross oversimplification as well. Now, we've talked a lot about autoimmune diseases in the past. In an autoimmune disease, your body becomes the foreign stuff. Your body becomes the antigen that triggers antibody production, and you start making antibodies against your own cells. And this is one of the ways that we can actually test for an autoimmune disease. You can go in and draw blood off of your patient and see, does this patient that we suspect has lupus, do they have antibodies against their own kidneys or antibodies against their own skin? That's one of the ways that we look to see if a patient has an autoimmune disease. So hopefully this is clear. We'll talk a lot more about antibodies as we go through lecture, If it's not clear, come talk to me during office hours, and I'll see what I can do to clear it up for you. Okay, last of our 3 blood cell types are platelets. Platelets are also called thrombocytes. Thrombo, if you remember, means clotting or blood clot. So thrombocytes are the little cells that make your blood clot. Technically, they're not cells. Technically, they're little tiny pieces of a big cell that break off. They are normally chilling in your blood, and when they're just chilling in your blood, they look like this, tiny little flat plates. When you have some kind of injury, then they become activated. They turn into this thing that looks like a thing out of a B-rated horror movie. Looks like the facehugger from Alien. All of those little projections that they have sticking off of them allow them to grab each other, and they play this kind of epic game of Red Rover. These platelets will stick to each other, they'll stick to red blood cells, and they will cover up wherever you're bleeding out. They also help to turn fibrinogen into fibrin. Fibrinogen is another one of the proteins that we find hanging out in our blood. And fibrin is just a long, thin thread. And the platelets use fibrin and they use red blood cells to make a clot, like a little net that they use to cover up wherever you're bleeding out. So you can see here, here's our platelets. Again, when they're just chilling, these are our activated platelets down here. That looks a little more terrifying. And this is fibrin. These little gray strings over here is fibrin that has trapped a bunch of red blood cells to make a clot and cover up where you have a cut. This is just an example of where all of your blood cells come from. Stem cells are responsible for making all of these, and your stem cell will differentiate into one of these 4, a megakaryoblast, an erythroblast, a myeloblast, or a lymphoblast. And hopefully you recognize that suffix blast in there. Remember, blast, B for blast, B for baby cell. A blast is an immature cell. Megakaryoblasts become platelets, erythroblasts become erythrocytes, and then something interesting happens with your white blood cells. You either have myeloblast or a lymphoblast. A myeloblast can become one of these 4 cells down here, a basophil, an eosinophil, a neutrophil, or a monocyte. A lymphoblast becomes a lymphocyte. So look at the difference between our prefixes here, myelo, lympho. One develops in the bone marrow, matures in the bone marrow, but your lymphoblast will travel to the lymph vessel and finish maturing there, and that's where we find them. Blood types refer to a little protein marker that is found on the outside of your red blood cells. There are a bunch of different blood typing systems, right now 33 that are recognized. The most familiar blood typing systems, the ones that you're familiar with probably, are the ABO and the RH blood typing system. This is where you talk about someone who's like A positive or O negative. We'll look a little more in detail at what exactly those mean. Blood types are important to match for blood transfusions because if you have a patient who has a certain blood type, maybe you have a patient who is O negative, and you give them the wrong blood type, you give them B positive blood, your body, their patient's body, is going to recognize that as something foreign. And it's going to do what we just talked about in the last lecture, or last slide. It's going to make antibodies that come and destroy that B positive blood. And then your patient's going to have a bad time in the ER. So really important to make sure that when you are donating blood, when you're taking donated blood and doing a transfusion, that you are matching the blood type that you're looking at. So let's look a little more in detail at your ABO and RH positive systems. We'll look first at ABO. So on everybody's red blood cells, you have a little protein that hangs out on the outside of the red blood cell. This is kind of like your "Hi, my name is" sticker that you put on your chest when you go to the event. This little protein is how your body knows that that red blood cell belongs to you. So if you are type A, you have a little type A protein on the outside of your red blood cell, chilling out there. If you are type B, then you have a little protein out there, but it's just the type B protein. It looks different than the type A protein. If you are blood type AB, is the rarest blood type that we have. Some of your blood cells make the type B protein. Some of your blood cells make the type A protein. You get a little bit of each. There's no like type AB protein. The last of our blood cell types, if you are blood type O, you got nothing. You got a little naked red blood cell running around. It has no protein marker on the outside of it. Now, where this gets tricky then is figuring out what type of blood you can give to somebody. So you can only receive your own blood type you are in a car accident, you need a blood transfusion, you can only get blood that's your type or type O. So for example, my blood type is A positive. So if I needed a transfusion, I could get type A because my body's already used to seeing that A protein. But I could also get type O because there's no protein on this little type O blood cell that will make my body realize that it's foreign. By virtue of type O being a naked red blood cell, it can go anywhere. It's like Harry Potter with his invisibility cloak. So anybody can get type O blood, and then you can only get your own blood type. So I'm A positive, I can get A or O. If you were, say, one of our rare people, if you were type AB, you could get type A because you have type A blood. You could get type B because you have type B proteins in your blood. You could get blood from someone who's type AB, or you could get someone from blood who's type O. Okay, what if you're on the other end of the spectrum? What if you are type O? Then where can you get blood? Can you get it from A or B or AB? No, you can't, because that A or B protein is going to be foreign inside your body, and your body will attack that type A or type B blood. So the only place where you can get blood, if you need it, is from a donor who is also O. So hopefully that kind of clears up our ABO. Now let's throw another wrench in there and talk about Rh positive and negative. Okay, let's make it even more complicated and talk about the Rh protein as well. Rh stands for rhesus factor. This is named for the rhesus monkey, not for the Reese's candy bar. And you can be either Rh positive or Rh negative. This is where the negative in being AB negative would come from. If you are, draw our little red blood cells. They're little red blood cells. Aren't they cute? If you are type Rh positive, that means that you make the Rh protein. It is also hanging out on the outside of your red blood cell. If you are Rh negative, you got another little naked red blood cell. You don't have the protein on there. That's what we mean by positive and negative. So like I said earlier, my blood type, and one of the most common blood types out there, is A positive. So my little red blood cell has both the A protein marker and the little Rh protein marker. My father, on the other hand, is A negative. So his red blood cell has the little A protein, but doesn't have the Rh protein. Again, if you have questions about this, come see me during office hours. It can be a little confusing when we talk about it. So this is another thing that we have to factor into blood transfusion, right? An Rh positive can receive both positive and negative blood, right? I can get A positive and A negative because that missing protein is not going to freak out my red blood cells. Somebody who is Rh negative can only receive negative blood. If we put an Rh positive blood cell in that person's body, their body will recognize that as foreign and will attack that blood cell because they've never seen that Rh protein before. So while I can get either A positive or A negative, my father, if he needed a blood transfusion, could only get A negative. Now he could also get O negative as well, but we're sticking just with our own blood types for now. So I could get a transfusion from my father, but I cannot give him my blood because that'll kill him. Or if it doesn't kill him, it will make him very, very sick. If you don't know your blood type, and most of my students don't, there are a few ways that you can find out. One, you can go to your doctor and you can request that they draw your blood and then they tell you your blood type. You can go to one of the 9 News health fairs that are around here every spring and fall. They canceled them for the spring because of the coronavirus, but you could go in the fall. They do a blood typing test for $35, I think it is. Or if you're really curious and you want to know and you also want to feel good about yourself, go donate a pint of blood at Bonfils. And in a couple of weeks, they will send you a nice little thank you card that has a note in it that tells you what your blood type is. That's how I found out my blood type. They also sell blood typing kits on Amazon. I'm not sure how much I trust those. I've never tested any of them. They're also kind of expensive. So, you know, if you're really bored during quarantine, you can get a couple of blood typing kits and like test everybody in your house. Have fun. So a couple of terms that you should know when we talk about blood types and blood donation. One is the universal donor and the universal recipient. O negative is our universal donor. By virtue of O negative having a completely naked red blood cell. It doesn't have an A or B, it doesn't have an Rh protein. There's nothing on the outside of that red blood cell that your body would notice as foreign. So anybody can get type O negative blood. Find the O negative person in your life and keep them very close. You might need them during the zombie apocalypse. If you are AB positive, you are the universal recipient. You can get blood from anybody. You can only donate blood to people who are AB positive, but you can take anybody's blood. So in a zombie apocalypse, I don't know, I guess you're set. The rest of this chart then is looking at where you can get blood from and to whom you can donate blood. That's what we see here. So if you are type A, or if you are type positive, Rh positive, you can take from somebody who is either positive or negative. That's what we see up here. Here's my blood type, A positive. I can get blood from someone who is A or O, and I can get blood from someone who's positive or negative. Here is my father down here. He's A negative, so he can only take blood from someone who is A negative or O negative. He can't have that positive protein. Now, I can donate blood to somebody who is either A positive or AB positive. My father's a little better when it comes to donating. He can donate to someone who is A positive or negative, and someone who is AB positive or AB negative. Okay, going from our blood typing, let's talk a little bit about immunity and the stuff that makes up your immunity. Immunity is what provides you protection against disease, protection against any kind of pathogen that would want to wreak havoc on your body. There are two different types of immunity, specific and non-specific. Non-specific immunity we call innate immunity. This is the immunity that you are born with. We've talked about some of these before. Remember when we talked about the integumentary system? Your unbroken skin is your body's #1 line of defense against infection. Cilia in your nose and in your trachea that will help catch viruses and bacteria, the mucus that lines your trachea and your nose as well. Bactericidal body secretions, you make an enzyme called lysozyme in your tear glands, and lysozyme washes over your eyes and it keeps them protected from bacteria that might get into your eyes. You also see this enzyme made in saliva, in breast milk, and a few other places as well. Your reflexes help protect you against immunity. Think about like your coughing or your sneezing reflex that will help you cough up bacteria that might get into you. Lymphoid tissue and phagocytes, these are cells, but they're non-specific. They'll just destroy any random foreign thing that they find. They're not tuned to destroy one particular thing or another. So that's non-specific immunity. Specific immunity you get during your life that's geared to a specific pathogen. This is not just your general protect me against everything immunity. This is what you get when you are immune to a certain disease. There are two cells that run this, T cells and B cells. T cells do this cell-mediated, B cells do this humorally. We'll look at what that means in a little bit. This is the idea behind, like, you got your rabies shot. I got my rabies shot before I went to Kenya. And now I am immune to rabies. If I get bit by a dog or a bat or a skunk or something, in theory, I won't die from rabies. I've never tested that. I don't really want to. I'm gonna hold on tight to that vaccine. So how does this work? Here's your little B cell, and your B cell has a little receptor on it. This looks very similar to the antibody that that B cell would make. And your B cell is just chilling in your blood, hanging out, maybe talking with your other B cells. And then all of a sudden, here comes, let's make it rabies. Here comes your rabies virus. Oh no, rabies. And that rabies will attach to the little receptor on the outside of the B cell. And when that happens, this T cell, who's also hanging out in your blood, notices that and sends your little B cell a text message, I guess. He releases chemicals that tell the B cell, hey, you have something stuck on you. And then when that happens, when the little B cell is told that, he starts to make antibodies. He churns out a whole bunch of antibodies because clearly there's going to be a bunch of rabies virus somewhere running around the system. That was a very simplified overview of how your B cells and T cells work. But for now, we'll call it good. So specific immunity, there are two different types. You get it either naturally or artificially. Natural specific immunity happens two ways. You either come in contact with a disease organism. So maybe I didn't get vaccinated against rabies before I went to Kenya. Maybe I went to Kenya and I got, bit by a bat. That would give you natural specific immunity if I lived through the rabies. Passive natural specific immunity happens when you get antibodies that go from one person to another. And this happens in 2 times in your life. It happens when you are not yet born, when antibodies come from your mother across the placenta into you. This is one of the reasons why, for those of you who have had kids, mom usually will get a Tdap shot a little later in pregnancy. That increases the amount of antibodies that she has in her blood, and those antibodies will transfer across the placenta into the baby. And then after that baby is born, breastfeeding is a huge source of antibodies for that baby. You hear it very frequently called a cheap vaccine, and that's because we know babies who are breastfed have much lower rates of respiratory infection, ear infection, They tend to do a lot better because they have lots of antibodies going from mom through their milk into their body. So that's natural specific immunity. Artificial specific immunity is me saying, I don't want to get rabies in Kenya because I'll probably die. Let's do something about that before I go. And that's where vaccination comes from. You guys remember the story of Dr. Jenner that we talked about in the integumentary system lecture when we talked about smallpox. So vaccination is an active artificial specific immunity. We are introducing part of a bacteria or virus, or the whole bacteria or virus weakened off significantly so that your body can play with it and look at it and learn how to build antibodies against that pathogen. The other way that we can do artificial specific immunity is by doing a serum transfusion, serum that has antibodies in it. And I think I mentioned this when, I'll mention this again when we talk about the respiratory system. This is a common treatment that we do when we have diseases that are really, really nasty on the body that we can't treat well. Oh, we talked about this with tetanus. You remember that painting that I showed you, the soldier with tetanus who had that really bad muscle spasms? So if you come into the ER with tetanus, they are going to give you serum that they've taken from another patient who has been vaccinated against tetanus that has lots of anti-tetanus antibodies in it. And those antibodies will help your body start to fight off the infection. We do this with tetanus. We do the same thing with rabies. Rabies is an unfortunate disease if you don't get treated for it. This is also kind of our go-to treatment if we have a disease that we don't really have a cure for that is giving us a lot of trouble. They're doing this right now with COVID-19, and you may have seen this in the news. They're asking for people who have had COVID-19 and gotten over it to come donate blood so they can take the serum from that blood and inject it into people who are currently sick with the virus, because that boost of antibodies will help the body fight off the virus. They also did this many, many, many years ago, back when we had the Ebola outbreak in West Africa. They were taking serum from patients who had survived and injecting it into patients who were sick to give them an antibody boost. I don't remember how well that worked. I don't remember seeing any reports on that. But when you have no other options, it's a really good idea. There are a bunch of key terms here. Again, I'm not going to read these off. You don't want to listen to that. But look through these. These will be very useful as you're working on your homework and as you are studying for the quiz. If you have questions about any of the terms on here, definitely come ask. Okay, some clinical stuff associated with the blood. Anemia occurs when you have low levels of hemoglobin in your blood. Anemia, if we pull that apart, here's our prefix "an," which you guys remember means without. And then our suffix "emia" refers to blood. So anemia literally means without blood. There are a lot of things that can cause anemia if you don't have enough red blood cells. Maybe you had a hemorrhage. That would make you not have enough red blood cells. If your red blood cells are very small, if they don't have enough hemoglobin in them, all of this can cause anemia. Your test for anemia, you'll do blood counts. You'll look at how much hemoglobin is in your patient's blood compared to how much you would normally see in a patient. Signs of anemia can be kind of vague. You'll see things like fatigue, shortness of breath, pallor, irritability. I mean, the fatigue and the irritability, that sounds like yesterday, right? Pallor is one that will indicate anemia. Look at your gums in the mirror. They should be nice and pink. In a patient who has anemia, they'll be very pale, maybe almost white. So different types of anemia. Aplastic anemia occurs when your bone marrow is destroyed. There's a lot of stuff that can cause this. Certain drugs will, toxins, some viruses that will come in and destroy your bone marrow. If you're exposed to high levels of radiation, this is always a concern when you have a patient who's going through chemotherapy and radiation. Or you see this in a patient who has bone marrow cancer. Their bone marrow just gets destroyed. Nutritional anemia happens when you are missing this intrinsic factor. This is a protein that helps you absorb iron and B12 out of your intestines. It's made by your stomach. And then sideroblastic anemia happens when your bone marrow starts churning out these weird little red blood cells that don't work properly. They're called sideroblasts, and you can see these little kind of bluish, they almost look like little blue crystals in them. Those are little iron crystals. The hemoglobin wasn't made properly. Hemorrhagic anemia, like I said earlier, if you bleed out, you will have anemia because you won't have as much red blood cells as you should. Thalassemia or Cooley anemia, these are hereditary genetic diseases. Your hemoglobin is mouse-shaped. It's a goofy shape, and that causes the red blood cells to rupture. That will also give you anemia. Sickle cell anemia is an interesting one. This is a genetic mutation, and it affects the way that hemoglobin, the little protein inside the red blood cell, is made. And if that hemoglobin is made improperly, that will cause the red blood cell's shape to be improper. And that's what we see down here in this picture. So you see we have a few nice, normal, healthy, pretty red blood cells. And then we have red blood cells like this that are kind of a half moon or a sickle shape. And this is where we get the term sickle cell anemia. Now, if you remember that picture that I showed you earlier, that little red blood cell squeezing its way through a capillary, kind of folded in half, your blood cells should normally do that. They go through a capillary one at a time. They're very good at staying in a queue. But when you have sickle-shaped red blood cells, they stick to each other, like we see right here. And when they stick to each other, they block blood flow through tiny little capillaries. And this can be very, very painful. You tend to see this a lot in the hands and in the feet, and your patient will experience really bad debilitating pain because they have these blocked blood vessels. They're not getting blood to their tissues. Now, because sickle cell anemia is genetic, do we have a cure for it? Can we cure it? And the answer is no. So far, we have not found a way to cure any of our genetic diseases. There are medications that you can take that will help keep those cells from sticking to each other. There are medications that will help with the pain. In some very severe cases of sickle cell anemia, you can do a bone marrow transplant in your patient. You would expose them to very high levels of radiation that would wipe out their bone marrow, and then you would give them bone marrow from a healthy donor, and that bone marrow would go repopulate inside their bones, and then they would make normal, healthy red blood cells. Now, this doesn't change the genetic mutation that they have. If they have a child, they will still pass on that sickle cell gene, but at the very least, they will have normal red blood cells for the rest of their life. Sickle cell anemia is an interesting disease. It's one of our genetic diseases that you see a lot in certain ethnic populations. For example, Tay-Sachs disease, which shows up almost exclusively in Ashkenazi Jews, though you do see it sometimes in French Canadians and Cajuns. You see alpha and beta thalassemia a lot in Asian populations. Cystic fibrosis is kind of your classic white person's disease. Sickle cell anemia shows up most frequently in people of African, Middle Eastern, Indian, and Mediterranean descent. And the hypothesis behind why do we see this disease in that population is because this is also an area where malaria is endemic. There's no malaria in the US. We used to have malaria and then we got rid of it. But in places like sub-Saharan Africa, the malaria has never been eradicated, came close once, and is there in full force. So the hypothesis is because the malaria parasite reproduces inside the red blood cell, if you have a patient who has a bunch of curved sickle-shaped cells, the malaria parasite isn't able to get in there and replicate in it. So that's the hypothesis behind why you see sickle cell in this population. It's a protective factor against malaria. There There are a bunch of coagulation disorders that you can see. Thrombocytopenia happens when you have low levels of platelets. There's a lot that you can see with this. Chemo will do this to your patient. Chemo does a number on your patient like this. And that's always something that you're checking for. If you have a patient who's going through chemo, maybe they have surgery scheduled in a week, you'll be checking their platelet levels to see if they have enough platelets to actually go into surgery. If they don't, you may need to get a bag of platelets out and give them a transfusion. You'll see this also, other conditions that would lead to thrombocytopenia, HELLP syndrome, which is a condition that you see in pregnancy, hemolysis, elevated liver enzymes, and low platelets. You see that as well. Disseminated intravascular coagulation is generally abbreviated DIC. And if you ask any ER nurse what DIC stands for, they'll tell you it means death is coming. DIC, interestingly, is a sign that we're seeing of coronavirus, kind of a new thing that we weren't expecting to see. When you see DIC in a patient, this is just a patient who's got lots of tiny little clots all throughout their blood vessels. And that's what we see in our patient right here, these dark patches on the skin right here. This is where they have a bunch of blood clots in that tissue. And those blood clots are blocking blood flowing to that area. So this tissue is low on blood, low on oxygen, and maybe dying off. Now, the big concern with DIC, if you have a patient who has lots and lots of little blood clots all through their veins, is those blood clots can get to the heart or to the lungs or to the brain and block those organs. And then you have, a very sick patient who is having a stroke or having a heart attack or having a pulmonary embolism. You see DIC a lot with certain diseases. This is really common in meningitis. Not uncommon for a patient with meningitis to go into DIC, and if they survive the meningitis, maybe lose a finger or toe or, gosh, even a whole arm to the meningitis itself. Hemophilia is a hereditary disease. This is, if you remember our talk about Duchenne muscular dystrophy, this is also an X-linked recessive gene, which means, if you remember, it's found on the X chromosome, and you have to have 2 copies of the gene to be affected unless you're a boy, because you only have 1 copy of the X gene in general. In hemophilia, you don't make a clotting protein that is active in the clotting cascade, and that's why your patient bleeds a lot. It takes them a very long time to clot. So this picture over here on the right, this is the clotting cascade. You do not have to memorize this. It's long and big and complicated. But the clotting cascade is essentially a bunch of dominoes all lined up, one after the other. Right? And when you push those dominoes, they all fall down. But if we were, say, to remove one domino, right, and we push our dominoes down, they're going to come this far and stop. The rest of them are not going to fall down. That's what happens when we have a patient with hemophilia. So there are 2 kind of pathways that we see that trigger ultimately what we're looking for in a clotting cascade, which is converting prothrombin into thrombin. There are 2 ways that we get there. And you can see a genetic malformation in either of these ways. So factor 3 is classic hemophilia, or factor 8, sorry, is classic hemophilia. That's this protein right here. It doesn't work properly. Also called hemophilia type A. The other type of hemophilia that we see is hemophilia type B, which is factor 9, this one right here. This is hemophilia B, or sometimes called Christmas disease. I don't know why they call it Christmas disease. That's the worst Christmas gift you could ever get. But if you have one of these types of hemophilia, it's going to take a lot longer to do this reaction, to convert prothrombin into thrombin. And all that means for you is that your patient's going to bleed a lot more than they normally would if they didn't have hemophilia. A patient who has hemophilia, and usually he's going to be male, is going to need to have these proteins, whichever one is missing, supplemented. He'll be injecting either factor 8 or factor 9 into his body, usually every other day, maybe every 2 days if he can go well, for the rest of his life. And this is very expensive. An injection of this costs, gosh, upwards of $1,000. It's a very, very expensive disease to have. Hopefully you have good insurance. If you're really big onto in history, there's some interesting stuff with hemophilia that goes on in the royal families of Europe. There's also a good example why you shouldn't marry inside your family. So Queen Victoria was Queen of England back in the 1800s. I should know that date. And she had the mutation for hemophilia. So she was XX with a little broken hemophilia gene. This was a random mutation that just sporadically cropped up in her. She didn't inherit it from anybody. It just happened. She married Prince Albert, who was from Russia, I think. And they had, as you can see, a whole bunch of kids. They had 6 sons and 4 daughters. If you're square is male, round is female. And she passed on that X gene, that hemophilia gene, to her daughter Alice. She also passed it on to her daughter Beatrice and to her son Leopold. So 3 of her kids inherited that broken X chromosome from her. And then we can trace the pathway of hemophilia through this family tree. So we start with Alice. She married, I don't remember who she married, and they had 4 kids. She had a daughter, Alexandra, and a daughter, Irene, who both were carriers as well. They both inherited that hemophilia. And then she had a son named Frederick William, who was hemophiliac, and then another, that's just her son. The blue box isn't her son. So she had 3 kids, Irene Alexandra and Frederick William. Frederick William, it says he died at age 3. He fell out of a window and had an intracerebral hemorrhage. He bled into his brain. This is not, the injury that happened to him would not have killed him had it not been for the hemophilia. He would have survived that fall and maybe broken a bone, but he would have been okay. Now, if we look at Alexandra, if you're familiar at all with Russian history, this is the last empress, the last Tsarina of Russia. She married Alexei, and they had a bunch of kids. They had a bunch of daughters, and then they had one son, Alexei, and he had hemophilia. He inherited that from mom. And actually his hemophilia proved to be the downfall of the Russians due to their crazy ties with Rasputin. It's interesting history. Ask me if you want to know about it. If we look over here at her siblings, so let's look at Irene. Irene got married to this guy, Henry of Prussia, who was her cousin. Your family tree should be a tree, not a wreath, not a Christmas wreath. She married her cousin, King Henry of Prussia, and they had 3 sons, Henry and Valdemir. Henry fell off a chair when he was 4 years old and also died like his, would that be uncle? Died like his uncle did from bleeding into his brain. Again, from an injury that would not kill a healthy person. Valdemir of Prussia, interestingly, lived to be 56. He needed a blood transfusion during World War II, and there was no blood available. I don't remember what happened that he needed a blood transfusion, but he bled out because he didn't have a blood transfusion available. So that's that half of the family. If we look at Leopold over here on the right, so Leopold was a hemophiliac. He got married and had 2 kids, a son and a daughter named Alice, and he passed his X chromosome to Alice. So remember, a father will only pass his X chromosome to a daughter. He would pass a Y to his son, and that Y chromosome was healthy. So Alice is a carrier and then she gets married and has 3 kids, one very young son who dies in infancy, and then this guy, Viscount Trematon, who also died from bleeding in his brain after a car accident, and he was hemophiliac. This line right here between Alice and Leopold and the Viscount is a good example of when you hear people talk about a gene that skips a generation. You've probably heard that phrase before. And that's what we see in this family line here. This gene didn't skip a generation. It's not like it disappeared during this generation and then showed up again in our Viscount here. What happened was Alice was a carrier, she wasn't affected. So even though she didn't show hemophilia, she still had the disease. That's what we mean when we say something skips a generation. And then if we look over here at Beatrice, the last of Queen Victoria's daughters, she got married, had a bunch of kids. She had Leopold and Maurice, her 2 sons. Maurice was killed in battle in World War II. Leopold died during a hip operation. He bled out on the table, again, because he had hemophilia. Her daughter, Victoria, you can see, was also a carrier. And Victoria had married Alfonso and had a bunch of kids, including Alfonso and Gonzalo, who both bled to death after accidents. So there's a lot going on in this slide here. I mean, hopefully you're seeing one, don't marry your cousin. Hopefully you're seeing how what we talk about when we say something skips a generation, and also how most of these people who had hemophilia met untimely deaths because they bled out due to an accident or an injury or medical need. So I think it's an interesting study in the way that a gene spreads through the population. In the current British royal family, those of you who got up late or early to watch the royal weddings, there is no hemophilia present. George VI did not inherit that from his parents. Okay, moving on. Neoplasm is just our medical term for a cancer. If we break this apart, neo means new, and then plasm means growth. So a neoplasm is literally a new growth in the body. That's not good. We have enough that we need. We don't want any more new growths. So that's why we refer to cancers as neoplasms. One person is diagnosed with blood cancer every 3 minutes in the US, according to the Leukemia and Lymphoma Society. Leukemia is the most common of those. You see these rapidly dividing but very incompetent white blood cells. Your bone marrow is churning out white blood cells that don't actually do anything. They don't protect you. They don't keep you safe. They don't fight off infection. There's just a bunch of them. Signs that you'll see of leukemia, anemia, fatigue. Your patient is very tired all the time. Easy bleeding is a big one. Easy bleeding and easy bruising. And that will usually bring your patient into the doctor. I have these bruises all over me. I don't know where they came from, and it takes a long time for them to heal. You'll also see, if you stick your patient with leukemia into a CT scan, you'll see splenomegaly and hepatomegaly. The spleen and the liver will be enlarged. Causes of leukemia, we're not entirely certain about all of them. We do know that if you're exposed to really high levels of radiation, that increases your risk of leukemia. If you have heard of Chernobyl, the nuclear meltdown at Chernobyl, HBO had that series not too long ago, or the atom bombs that were dropped on Hiroshima and Nagasaki, you see lots of levels of leukemia in those populations afterwards because they were exposed to very high levels of radiation. It can run in families, and you can sometimes see leukemia after a viral infection. Again, that's kind of our diagnosis du jour when we're not sure what else is causing something. It's probably a virus. There are 2 different kinds of leukemia. They either originates in the bone marrow or it originates in the lymph nodes. Treatment for leukemia is kind of your standard cancer treatment: chemotherapy, radiation, a bone marrow transplant if your patient needs it. data from the National Institute of Health. It's a little old, but the trends that we see here are still pretty steady. So you can see there's a slight increase in numbers of leukemia, a little bit, not much, a % or 2. But you can also see death from leukemia is going down by a % or 2. That's pretty good. Your 5-year survival rate for leukemia is 61%. So a little over half of your patients will still be alive 5 years after they've been diagnosed with leukemia. Hodgkin's disease is a form of lymphoma that you see usually in the lymph nodes. Your sign of Hodgkin's disease are these giant Reed-Steinberg cells that crop up in the lymph nodes. You also kind of see these in non-Hodgkin lymphoma as well. Non-Hodgkin lymphoma is the more common, more lethal form of lymphoma. And then multiple myeloma is fairly rare. This is cancer of your bone marrow. You don't see a lot of it. This is looking at your 5-year survival rate of those 4 different types of blood cancer, then myeloma, Hodgkin, non-Hodgkin, and leukemia. And you can see for all of them, the survival rate has increased, which is true of all of our cancers, more or less. They're all going up. But you can see in different rates. Back in the 60s, we were looking at pretty low survival rates of like myeloma and leukemia, while both of those have increased a lot. Hodgkin lymphoma, we had higher survival rates, so we have a higher survival rate now. The reason why we see these differing survival rates probably is because lymphoma, which had higher survival rates to begin with, is the most common type of blood cancer that we have. So we know more about it, we have more research on it. Myeloma, which had the lowest survival rate, is pretty rare. We don't see it a lot, we don't really have as much research into it or knowledge behind how to treat it as we do lymphoma. A hypersensitivity is the medical term for an allergy. It just means that you are excessively sensitive to an allergen. An allergen is what triggers the allergy. So if you are allergic to pollen, pollen is your allergen. Or if you are allergic to peanuts, there is a protein in the peanuts that is the allergen that triggers your allergic reaction. I once had a student, he had to write down the other word for a hypersensitivity. I was looking for the answer allergy, he put down snowflake instead. That is not the correct answer, that is not the same as hypersensitivity. An anaphylactic reaction happens when you have a very severe hypersensitivity. Probably we've all had allergic reactions before. I mean, think about the spring when everything's blooming and you're itchy and sneezing and watery eyes. But a severe allergic reaction happens when you're exposed to something that you have a very, very strong hypersensitivity for. This is what we usually think of when we think of like the kid who's allergic to peanuts or the kid who's allergic to bee stings. When this happens, you go into anaphylaxis and the tissues of the trachea start to swell and the trachea starts to get cut off. To treat this, you use epinephrine, you use your EpiPen. You inject epinephrine into your patient to open their trachea back up so they can start breathing. The EpiPen is kind of your bridge between the beginning of the allergic reaction and the ER. An EpiPen will last for roughly 20 minutes. And then after that, your patient's symptoms will start coming back. Now, the answer to that is not, oh, that's okay, I have a second EpiPen, we'll just double fist it. The answer to that is we need to get to the ER as soon as we give this patient the EpiPen, because we only have about 20 to 30 minutes before they start going back into anaphylactic shock. A delayed hypersensitivity reaction is a reaction that takes a while to occur. You have to have certain damage to the tissues. This is what you see in poison ivy. You get those oils from the poison ivy on you that causes damage to your cells. Your cells start to get destroyed by your T cells. And this is what causes the inflammation and the weeping that you see with a delayed hypersensitivity reaction. All right, immunodeficiency. This is always a fun topic. Immunodeficiency is any time that the immune system fails. And there are a number of types of immunodeficiency that you can be born with. These are genetic or inherited, or sometimes they just crop up. SCID, XLA, CVID, these are your patients just born without a functioning immune system. They can't make antibodies, or they don't make antibodies properly. So you can imagine this patient has a lot of issues with illness. They get sick very easily and very often. Now, that's inherited or innate immunodeficiency. When we talk about immunodeficiency, usually we're talking about something that's acquired. Specifically, acquired immunodeficiency syndrome, which is the last stage of an HIV infection. We talked about this a little bit in the integumentary system when we talked about the skin. Remember, I said nobody dies from AIDS. I had a class, my last class, got really up about EZE and EZE dying from AIDS. I'm not sure why they did, but they were very into this. So nobody dies from AIDS. What you die from is some other type of infection. We talked about Kaposi sarcoma when we talked about the skin. Sometimes you'll see pneumocystis pneumonia, thrush, cryptosporidium, cryptococcus. Those kinds of things are what come in and then, for lack of a better term, finish you off. Oh, I remember what it was about EZE. I had a student who was going to win a bet against her boyfriend because her boyfriend said that EZE died from AIDS, and she said that he didn't. He died from AIDS-related causes. She was very proud of herself. Anyway, let's look at HIV. So how do you get HIV? You get HIV when your body fluids, which are all of these here, blood, any kind of sexual fluids, breast milk, come in contact with mucous membranes in your eyes, your mouth, nose, rectum, urethra, vagina, any of these, or come in contact with broken skin. So any of those body fluids in mucous membranes or in broken skin, that is how you transmit HIV from one person to another. You can also transmit HIV from mother to child. It will cross the placenta and go into that unborn baby. You can also transmit HIV through breastfeeding. And these are big concerns when we talk about maternal child health in areas where HIV is endemic. Sharing needles or sharing razor blades will also contribute to HIV spread. Don't do that. The vast majority of cases of HIV, though, are from some kind of sexual contact. Ways that you cannot get HIV, you see down here, you cannot get it from just general contact with a person, touching them, hugging them, sharing food or drink or plates or cups. You cannot get it from toilet seats. That is not how this virus is spread. There are 3 stages to an HIV infection, and they take a while to go through. So just because you have HIV, you didn't get diagnosed with HIV yesterday and tomorrow you wake up in full-blown AIDS. It does not work like that. The first stage of an HIV infection is called your acute primary infection, and this happens about 1 to 4 weeks after you got the HIV into your system. During this time, you'll see kind of general flu-like symptoms: cough, sore throat, maybe fever, aches, pains, chills. It sounds like a cold. None of you, the last time you woke up with a cold, probably your first thought was not, oh no, this must be HIV. Probably your first thought was, oh, I have another cold. You never called into work like, I can't come in, I feel like death, I think I have HIV. Try that. Let me know what your boss says. So most people going through the acute primary infection don't think that they have HIV. They think that they had a cold. During this time, you have really high levels of virus in your blood, so it's very easy to spread this virus to somebody else. On top of that, about 50% of your people who go through stage 1 are asymptomatic. So they don't show anything. They feel great. After this acute primary infection, you go into the second asymptomatic stage that can last for a really long time, 10 to 15 years. During this time, like the name of the stage says, you are asymptomatic, so you don't show a lot of symptoms of HIV. You still have virus in your blood. You still have fairly moderate levels of virus in your blood, so you can still pass it on to somebody else. After that 10 to 15 years, and the length of that time determined by a lot of things, how good is your overall health, for example. After that 10 to 15 years in the asymptomatic stage, then you go into this last stage, stage 3, where you are actually symptomatic. This is symptomatic HIV, or what we call acquired immunodeficiency syndrome. In this last stage, you have a really, really high viral load, and this is where all of our opportunistic infections come from. Kaposi sarcoma, pneumonia, tuberculosis. If you are in this last stage, this stage 3, without treatment, you'll live about 3 years, and then will eventually die probably from Kaposi sarcoma or tuberculosis. Now, all of these stages here, the length of time that I've given you, this is if you don't have treatment. If you do have treatment for HIV, you can live a normal lifespan. You can live into your 70s and your 80s, and, which is even more important, you can decrease the level of HIV in your blood to the point where you can't find it in a test. And that's the goal of good HIV treatment, is to have your patient on their medications, have them taking their antiretroviral medications regularly to the point where you can't find any more HIV in their blood. Now, when you hit that point in your HIV treatment, is your patient cured of HIV? No. And if your patient goes off of their medication, the levels of virus will rise again. So the goal here is to keep them on their meds, for the rest of their life. And this treatment will protect the people around them as well. For example, if you have a woman who's pregnant, mama gets pregnant, and you put her on antiretroviral medications, we know that she has a very, very small chance, like a 2 or 3% chance of giving HIV to her baby. She can breastfeed that baby for the full 6 months and not worry about passing HIV on to the baby. If you have a couple, a discordant couple, maybe he has HIV and she doesn't, if they are both taking antiretroviral medications, he will not pass HIV to her. So we have spectacularly good antiretroviral drugs. They have come a long way since the 70s and the 80s when we first started testing and trying to cure HIV. This chart right here, I think, is interesting because it really hits home what we just talked about with the span of HIV. So this is from 1990 to 2010, kind of when HIV was at its heyday. Our little blue line here, this is new HIV infections each year, and then the gray line is AIDS-related deaths. And you can see right here, we kind of peak highest levels of new HIV cases between like 94 to 97. And then if we look further down our chart here, we kind of peak with AIDS-related deaths. We get the highest number of AIDS-related deaths between 2004 and 2007. About 10 years apart, which, if you remember, is about the lifespan of your asymptomatic stage of HIV. So these people in this kind of column right here are now the people in this column right here. I think this shows really well that 10 years that you have asymptomatic for HIV. This is data from 2017. I need to find some more up-to-date stuff for 2018. There are, in 2017, we had almost 2 million people who got a new HIV infection worldwide. This is significantly decreased, almost 20% since 2010. That's really good. You can see worldwide numbers of HIV or rates of HIV are decreasing. There are two parts of the world where we're seeing increases in HIV. One is Russia and Eastern Europe. One is MENA, the Middle East and North Africa. Why are we seeing increased rates of HIV in these places? We're not quite sure what's going on there. Obviously, the part of the world with the largest number of HIV cases is Sub-Saharan Africa, Western and Central Africa, Eastern Africa in particular, just because HIV kind of originated in this sort of Central Africa region right here, I think around the DRC and Uganda. The goal for 2020, which was almost met for worldwide HIV, was that 90% of people who have HIV know that they have HIV. And then out of those people, 90% of them are on treatment. And out of all the people who are on treatment, that 90% of those people are virally suppressed. And that's what I meant. You can't find the virus in their blood anymore because they're taking their drugs regularly and actively. The other goal was also fewer than 500,000 new HIV infections annually. Clearly, we did not hit that one, as you saw with our nearly 2 million new infections back in 2017. So how did we come? We came really, really close. In 2018, 79% of all people who had HIV knew that they had HIV, so that's close. Out of those people, 78% of them were on antiretrovirals, which is 62% of all people who have HIV. And out of all the people who were on antiretrovirals, 86% of them, you could not find the virus in their system. So that's 53% of all people who live with HIV. We came very close to the 90-90-90 targets. I have to look up what we officially get this year. We might actually make it. So let's go from worldwide to just the US. These are new diagnoses of HIV in the US back in 2017, broken down by age category, which is what we see down here. So we have 13 to 24 years old, 25 to 34 years old, 35 to 44 years old, 45 to 54, 55 to 64, and then 65 and older. Who is getting the most HIV in the US? The 25 to 34-year-olds, and by a lot too. 13,000 new cases of HIV. That's almost double this and this, almost twice as much. So that young adult population, that 25 to 30-year-old age range, is the one where we see the most cases of HIV, which is bad. If we further break down where we see HIV cases based on race, based on gender, and based on sexual activity, we start to see even more interesting data that suggests where we need to start working on curbing our AIDS outbreak. So the red columns here are men, the blue columns are women, and then you can see over here on the left, so our top column, the most HIV cases that we had was Black male-to-male sexual contact. So Black men who have sex with men, either gay or bisexual. After that, our second highest was Latino, Hispanic or Latino, and then white men who had sex with men. That was our top three categories. After that, Black women, heterosexual contact, and then Black men, heterosexual contact, Hispanic women, and then white women. And actually, these two used to be switched. It used to be white women had more HIV than Hispanic women. That changed in the past year. So other populations then that we need to be targeting for HIV care, besides our 24 to 35-year-old age range, also clearly are ethnic minorities, right? Black and Hispanic, and see disproportionately high rates of HIV. In particular, this population here, there is a big outbreak of HIV right now in the South, in the Black community among men who have sex with men. There's not a lot of resources down there for HIV testing and treatment. There's a lot of shame and stigma surrounding it. So we're seeing in places like Alabama, Mississippi, Georgia, very high rates of HIV in this population, which is also, I think, explains why you're seeing then, after men who have sex with men, the next highest rate is Black heterosexual women who maybe are getting HIV from a partner who is also, sleeping with men on the side or something like that. It's a delicate epidemiological case to tease out. So With that said, there is some good news about HIV in the US. Overall, among young adults, HIV is decreasing. It's decreased significantly in women. It's remained stable in men. And again, a lot of this has to do with this men who have sex with men just disproportionately have very high rates of HIV. You can see it's decreased in Black and African American men, has increased in Hispanic men who have sex with men. So how do you know if you have HIV? Hopefully by now y'all are nice and scared. So let's talk about where do you go to find out if you have HIV. The CDC recommends that you get one test for HIV at least once in your lifetime. You can go to your doctor for that. There are STD testing clinics around the city that you can find. You can go to Tri-County Health, which is the health department for Arapahoe and Adams and Douglas County, and you can request an STD test and an HIV test there. If you actually like legit want an HIV test and you're not sure where to go, come ask me. I can find a place for you to go. If you fall into a high risk category for HIV, then it's recommended by the CDC that you get an HIV test every 3 months. Who would fall into our high risk category? We've already seen a couple, obviously men who have sex with men. If you have ever had sex with someone for drugs or money, so visiting sex workers. If you share needles for injecting drugs, if you have a high number of sexual partners, all of that would put you in a high risk category for HIV, and you should be getting tested for HIV on a pretty regular basis. Okay, moving on from HIV, again, if you have questions about that, drop by office hours or send me an email. I can get you some resources. We've talked about autoimmune diseases before. You remember, this is when the body starts to attack itself. You have an immune response to your own tissues. And this can be either because the immune system has failed, or what is becoming the more common hypothesis behind autoimmune disease, maybe you had a virus and that virus mutated your cells and now they don't look like they used to and your body doesn't recognize them anymore. This is what happens, for example, in type 1 diabetes mellitus. Lots of examples of autoimmune diseases over here. Some of these we've seen before, like lupus and sclerosis and rheumatoid arthritis and fibromyalgia. Some of them we will talk about in the future, like Graves' disease, for example. Okay, last topic for this lecture. I think this will be an interesting one. Who's that? I popped this up in class once and one of my students goes, it looks like they're dancing. It does kind of look like it's dancing. That is, it's not a parasite, it's not a worm. It's very, very small, microscopically small. If I give you some more context, does that help you figure out what it is? That is the Ebola virus. So that's the Ebola virus. This is a picture from, I think, the DRC. They're having some bad issues with Ebola right now. This picture here, this is from an outbreak of Lassa fever in Nigeria 3 years ago, I believe, which is very, very similar to Ebola. The pictures are rough. So viral hemorrhagic fevers. These are a bunch of different viruses that cause hemorrhage and fever. They cause infections all throughout the body. They interfere with blood's clotting ability. They keep your blood from clotting, which is why you see the hemorrhage. They're spread by contact with infected people or infected animals. Ebola, we know, jumped into the human population through bats and through apes. There's no cure for any of our viral hemorrhagic fevers. Only a few of them have vaccines. Your classic sign of a VHF, obviously a fever, usually a very high fever, dizziness, fatigue, weakness, usually muscle and joint pain, and then the hemorrhage part, internal and external bleeding kind of from everywhere. Lots of different types of VHFs, dengue, yellow fever. Yellow fever we actually have a vaccine for. You have to get that vaccine to enter or leave certain countries. I had to get it to go to Kenya. I had to show that I'd had it so that they would let me leave Uganda. Crimean Congo fever, Ebola fever, Lassa fever, Marburg fever, which is a really scary VHF. We'll talk specifically about Ebola just because it's been in the news a lot in the past, 10 years or so. So originated from Central Africa, kind of this region right here between the DRC and South Sudan. The natural host of Ebola, we can find it chilling in fruit bats and in primates. That's the hypothesis is probably some hunter shot a bat or shot a primate and got some of the blood into their body. And that's how this person, this hunter, spread the disease. That's how it jumped from one population to another. The incubation period of Ebola is pretty standard for a virus, between 2 days to 3 weeks. And the symptoms are very similar to what we just saw: fever, muscle pain, weakness, bleeding, vomiting. It also does a number on your kidneys and your liver. That's one of the reasons why it's so lethal. Aside from the hemorrhaging. It's spread through contact with body fluids. Just about any body fluid that you have. The sexual contact thing is a new one. We didn't know this, but in studies that have been done on survivors of the Ebola outbreak in West Africa, we found that Ebola will still hang out in men's semen up to 6 months after they've been cured of Ebola. That's not what you usually think of when you think of an STD. Usually you think of gonorrhea or chlamydia or something like that. Nobody is calling up their girlfriend telling them, hey, doc said my Ebola test is clear, we're good. So something to consider. Ebola can also be spread through breast milk from mom to the baby. Right now, we have no cure for Ebola, and the case fatality rate is approximately 50%. So you get Ebola, flip a quarter, heads you live, tails you die. There are different strains of Ebola that have different varying levels of case fatality. I think the one that was in West Africa was the 90% case fatality, which is one of the reasons why it was so very, very overwhelming to the medical system. Now, there's no treatment. There is a vaccine, the ZBOV vaccine. This developed at the end of 2016, I believe, and so far has shown immense promise. It is very, very effective. The first study that they did, they took a bunch of people in West Africa, I think it was either Liberia or Sierra Leone, and gave them all either the vaccine or a placebo, and then watched them after 10 days to 2 weeks to see if they developed Ebola. There were 23 cases of Ebola in the group that didn't get the vaccine. There were 0 cases of Ebola in the group that did get the vaccine. So this is good. This is what we like to see in a vaccine. And also, a year after getting the vaccine, you still have pretty good levels of antibodies, which is, again, something that you really like to see in a vaccine. So this looks very promising. It's being used right now in the DRC. The DRC was almost Ebola free, and then a couple of weeks ago, I think back at the beginning of May, they found a couple more cases kind of here near Goma. So it's being used right now in the DRC to treat those Ebola outbreaks. So the typical pathway of Ebola through a human, you can see usually about 2 to 3 days between your first symptoms to when you start to get really scary symptoms, and death within, a week or so. It kills you very, very quickly. That's one of the reasons why it's such a terrifying disease. So there was a lot that went right and a lot that went wrong, mostly from the global response to Ebola. There was a lot of education that went out. This, frankly, is kind of similar to what we're seeing now with trying to educate the public about coronavirus. You're seeing the same kind of push. Lots of education about not handling dead bodies or people who are sick, Don't travel if you're sick. Report any cases. Signs and symptoms of Ebola. Usually when we talk about this, my students are like, oh my gosh, why would you touch a dead body? Gross. But remember that in the US, we are very, very separate from our dead. We put old people in nursing homes. We send people after they die to a morgue. There is no morgue if you're in the middle of the bush in Liberia. And as a tradition and as a sign of respect, it's very common. One, the whole village churns up at a funeral, everybody. And two, it's very common to touch the body of a deceased person as a sign of love and as a sign of respect, as a way to say goodbye. Unfortunately, this means if your person died from Ebola, you're spreading that virus around at the funeral. And there were a number of cases of really, really big clusters of Ebola that suddenly popped up after a funeral. So there was a big push to address that cultural practice, which, you know, we're seeing big pushes to address cultural practices that we have here that everybody's fighting against. Wear a mask when you go out in public. Stop gathering in large groups. There are very similar overlaps to the public health messaging that you saw with Ebola, but also that you're seeing now with COVID. One of the big reasons that you saw this push against like stop washing a dead body, stop hiding dead bodies, is because, I mean, imagine if that was your mother, your father, your kid. People are going to come, take your dead family members, spray them down with bleach, stick them in a bag, and send them away. You can't hold a funeral. You can't respectfully say goodbye to them. And frankly, if that right there, that's your mom, that's your dad, is that how you want the rest of the village to see them? Stretched out dead on the floor, getting sprayed down with chlorine? No, that's horrible. So you saw a lot of issues with people hiding sick relatives. They didn't want them to be taken away to go to the hospital. They didn't want them to die without them there, which you can completely understand. So the infectious period, or not infectious period, the incubation period of Ebola, if you remember, is between 2 days and 3 weeks, 2 to 21 days. And generally speaking, if you were going to travel fast, it only takes you about 26 hours to get from Brazzaville, to get from the Congo to here in Denver. Now, it costs like $4,500, so you're going to pay through the nose. But you can easily get from Brazzaville to Denver underneath that incubation period. You know, you were exposed to Ebola yesterday. I'm getting on the plane today. Maybe I don't start showing symptoms for a couple of days. I mean, we saw this same pattern when we saw the beginning outbreaks of the coronavirus as well, right? People traveling back from China because of the Lunar New Year who had who had corona but didn't know it yet. And think about all of the places you're going to go through as you're traveling back from the Congo to Denver. You're first going to go through some big airport in Europe, probably Charles de Gaulle up in Paris, Detroit Airport, which is also pretty big, and then DIA, which is also really big. You know, if you are at the beginning stages of your Ebola outbreak, it'd be very easy for you to spread that virus around as you're wandering through the airport, not to mention while you're sitting on the plane. And I talk about this because reflecting back on that vaccine that we have for Ebola now, that vaccine was fast-tracked. The CDC, the World Health Organization, Sanofi Pasteur, a bunch of organizations came together and they eliminated a lot of red tape. They eliminated a lot of steps that you would have to take to get a vaccine approved. They got together a whole bunch of funding very quickly. They fast-tracked that vaccine to get it done within, you know, a year to a year and a half. It takes decades. If you make a vaccine the standard way, it takes decades to get a vaccine made. Why? Why did they all of a sudden ramp up production of that vaccine for Ebola? I mean, we'd known Ebola has been around since the 60s. We've known it's a terrifying disease. The reason why they finally got their act together and finally started working on an Ebola vaccine, what happened with that big outbreak over here in West Africa? What happened that was different this time? Ebola started coming home. Ebola started coming to other parts of the world. We had patients who, usually doctors or nurses who were working on the outbreak, who came to Sweden and France and Spain and the UK, a bunch of people who came to America who had Ebola. And sadly, that was the impetus that we needed to start working on the vaccine. Not that Ebola is terrifying, but all of a sudden people realized Ebola can come here too. And that's why that vaccine was fast-tracked. A lot of ethical quandaries that we can discuss about that later. So if you traveled at all, or heck, if you were even at the doctor's office when Ebola was big, you saw a lot of information asking, please, if you've been outside of the country, tell someone if you feel sick. Help for all travelers from Africa, you see here in Australia. I was in Haiti during the Ebola outbreak. They had signs in Haiti telling if you had signs and symptoms of Ebola and you'd been to Africa, please tell someone. If ever there was a country that did not need an Ebola outbreak, it's definitely Haiti. I like this comic. I think it makes the point very nicely. And I think that point has definitely been ramped home now that we've seen COVID spreading across the world. Here's our vaccine. Here's our little ZBOV Ebola vaccine that, who knows, hopefully might be the end of our nasty Ebola outbreaks. So with that said, a bunch of key terms at the end of the presentation here. Again, these will be very helpful for your homework. As always, if you have any questions or concerns, or you want to know where you can go get an HIV test, feel free to send me an email or drop by office hours. I'd love to see you.